So my name's Sarah, and today I'm going to talk to you about factor deficiencies. So first I'm going to start off with a little bit of background, just to jog everyone's memory. So what is hemostasis? Hemostasis is a carefully balanced process by which the body maintains blood in a fluid state within the vasculature and prevents blood loss from the vascular system upon injury. So there's three phases of hemostasis: the primary, secondary, and then there's fibrinolysis as well. So during the primary phase, that includes the formation of a platelet plug. The secondary phase includes the formation of a more stable fibrin clot, and fibrinolysis is the degradation of the fibrin clot once the tissue healing has completed. So hemostasis is kept in balance by activators and inhibitors of clotting and fibrinolysis. Clotting occurs when blood vessels are damaged and activators of coagulation are exposed or released. Clotting is controlled by the initiation of fibrinolysis, and inhibitors of both clotting and fibrinolysis serve to bring the system back into balance. An imbalance in the activation or inhibition of either clotting or fibrinolysis causes thrombosis or bleeding. So I've got a case study here of a 68-year-old male who has a previous history of prostate cancer. He presented to the hospital in May 2013 for a liver biopsy, which came up with that the patient had micronodular cirrhosis with hepatitis and hepatocellular carcinoma. So he's not having a very good day. So on the 3rd of July 2013, the patient was offered a transcatheter arterial chemoembolization, or TACE for short, to combat his liver cancer. And in late July 2013, the patient underwent this procedure. So here are some of the patient's coag results before his TACE procedure. You can see that his INR, PT, and APTT are all around their normal ranges. If anyone needs a refresher, so your normal INR ranges are around 0.8 to 1.2. Normal PT range is about 11 to 13 seconds, and the APTT ranges are about 21 to 35 seconds. So during December 2013, the patient presented to the hospital with perrectal bleeding. So this is sometime after his TACE procedure. And his coag results, so these ones down here on the 19th of December, show that his INR, PT, and APTT have increased, and with the INR up here on the 23rd of December, reaching a maximum of 8.9. So individual coagulation factor deficiencies, factor inhibitors, and lupus anticoagulants can result in prolonged clotting times. Mixing studies performed on the 20th of December 2013 over here show that the clotting times don't correct. This indicates that the patient does not have a factor deficiency, but more likely a factor inhibitor or a lupus anticoagulant. Mixing studies do not correct coagulation times when an inhibitor is present, as both the patient's plasma factors and normal plasma factors are affected by the inhibitor. So I've got a bit of a graph here. Determining whether the patient has a lupus anticoagulant or a factor inhibitor can often be difficult. Lupus anticoagulants often result in false positives in an inhibitor assay, and if there's an inhibitor present, they can often result in a false positive if the scientist does a lupus anticoagulant assay. So we can use parallel line bioassays to determine whether a patient has a factor or an inhibitor, a factor inhibitor or a lupus anticoagulant. So in a line bioassay, so these are the results here. Clotting times of dilutions of a reference plasma, which is this one here, the reference plasma, and patient plasma, which are these two here, are plotted against the corresponding factor activity. Parallelism, so that's shown by the reference plasma here and this factor IX inhibitor. So parallelism of the curves between the reference plasma and patient plasma is essential to determine whether a test is reliable or not. And if the curve is non-parallel to the reference plasma, like this one here, then this may be an indication of a lupus anticoagulant. This assay is limited, however, in that non-parallelism is only seen in high titers of lupus anticoagulants with lupus-sensitive assays. So if the bioassay produces parallel lines, like this one, specific inhibitor tests such as the, I think it's Bethesda assay, can then be performed in order to determine which factor inhibitor is disrupting hemostasis. So the Bethesda assay can be altered for specific inhibitors. However, it's most commonly used for finding factor 8 and factor 9 inhibitors. In the case of this particular patient, it was found that the gentleman had a factor 5 inhibitor, which is quite rare. So, give you a background on what factor 5 is. The less common name for factor 5 is proacylaurin, I think that's how it's pronounced, which is a large glycoprotein produced in the liver and is a part of the common pathway in the coagulation cascade. So here's factor 5 down here. So the plasma concentration of factor 5 is usually around 5 to 10 micrograms per milliliter. So factor 5 is a cofactor in the prothrombinase complex. So here's a diagram of the prothrombinase complex here attached to an activated platelet. The prothrombinase complex is made up of factor 10A, factor 5A, and prothrombin. Factor 10A and prothrombin are bound to the activated platelet by calcium bridges, which you can see here and here. And the prothrombinase complex serves to optimally activate prothrombin to thrombin. So here's a bit of a better picture. So the picture here depicts the prothrombinase complex again. Factor 5, you can see here, is activated by alpha thrombin and binds to a specific site on the activated platelet surface. So factor 5A is the activated version of factor 5. And it serves as an attachment site for factor 10A. So over on this side, you can see that factor 10A has connected to factor 5A. The thrombinase complex then converts prothrombin to thrombin, as you can see here. And then thrombin converts fibrinogen to fibrin and clot forms. So factor 10A, just a side note, is also able to convert prothrombin to thrombin without the help of the prothrombinase complex. However, the thrombinase complex makes this process a lot more efficient. So a factor 5 inhibitor is an acquired alloantibody and usually manifests 7 to 10 days post-operatively. It promotes factor 5 clearance from the circulation, or it can also interfere with its coagulation function. And clinical features of this can be highly variable. They can be asymptomatic, or they can include severe to fatal bleeding. So possible causes for an acquired factor 5 inhibitor. Most are actually idiopathic, and we don't know why they occur. Others have been found to occur after the use of bovine fibrin glue. And others have occurred due to an association with surgery, exposure to aminoglycosides or beta-lactam antibiotics, infections, blood transfusions, autoimmune disorders, malignancy, and pregnancy. So the patient has a few predisposing factors which may have caused him to develop a factor 5 inhibitor. These include his surgery that he had and his malignancy, so his liver cancer. In the case of this patient, it was suggested that the TASTE procedure performed in July 2013 may have been the cause for the acquired factor 5 inhibitor. So what is a transarterial chemoembolism? It's a minimally invasive procedure where a small incision is made in the groin area, and it involves the blocking of blood vessels with either metal coils or gels to cut off the blood supply to a tumor, while directly injecting it with high doses of chemotherapy. This deprives the tumor of blood and allows a higher dose of the chemo drugs to be administered to the site. As the blood supply is temporarily blocked, this also prevents the drugs from entering other parts of the liver and the body, and keeps the chemo drugs at the site of the tumor for a longer period of time. TASTE is often used to shrink or eradicate small vascular primary liver cancers and can often slow the disease progression in liver cancer patients. TASTE can also be combined with other therapies to increase its effectiveness. It was suggested that bovine fibrin glue may have been used during this procedure. So I'll give you a bit of background on what bovine fibrin glue is. It's a cryoprecipitate blood product that has a high concentration of fibrinogen, fibronectin, von Willebrand's factor, and factor 13, and it also contains other plasma products. It can be clotted with thrombin to form a tough adhesive coagulum that has been found to be clinically useful as a fibrin glue. The cryoprecipitate and the thrombin are kept in separate compartments So here's a picture of what one of the needle syringes look like to administer the fibrin glue. So the cryoprecipitate would be kept in one side, and then the thrombin would be kept in the other side. And they're kept separately so that the coagulum is not formed until it's applied to the area it's needed. It's commonly used to repair dura tears, bronchial fistulas, corneal transplants, and for achieving hemostasis after cardiac surgery. Can also be used for spleen or liver trauma or leaking vascular sutures. Exposure of the recipient to the bovine thrombin may lead to the production of a bovine thrombin antibody, which, if formed, this antibody will persist and permanently interfere with the thrombin clotting test time. So patients with acquired factor V inhibitors are often treated with steroids, cyclophosphamide, which are cancer and autoimmune, used for cancers and autoimmune disorders, cyclosporine A, which is often used for autoimmune disorders as well, or intravenous immunoglobulin, again used for immune disorders. So the patient was originally given 75 milligrams of prednisone, which is a corticosteroid, around early January 2014. So we're looking in this part of the diagram. You can see it has a slight decrease in the patient's INR afterwards. And then during early February, the patient is given rituximab, which is a monoclonal antibody against CD20 B cells, and this is given twice weekly with prednisolone, which is a glucocorticoid, and it improves the INR to 3.7. Then on the 21st of the 3rd, so looking around here now, the patient is given steroids with rituximab again and prednisolone, and his coag results return to normal and are almost the same as they were before his TACE procedure. So these are his original results before his TACE procedure, and they're quite similar. And that's all I've got.
Wow, that was a very brave case to take on. Well done, that was good. So is there any questions for Sarah? I'll throw to Emerald first.
Just wondering, was there any chance with this patient of relapsing with the condition? Or once the treatment's finished, was it stable?
So relapsing with his coag results?
Yeah, that's correct.
I think they're keeping him on the rituximab and the prednisolone. I think he has it every 4 weeks, it was, to keep his INR down, I think. Looking at Ailey.
Don't look at me.
I think he might be on drugs for life.
Yeah.
And yeah, so he'll be on the rituximab and the prednisolone 4 weekly, probably for life. Yeah.
Any questions from Townsville? Yes, Ailey's
You
there.
answered most of them. You did very well. That was extremely detailed. Well done. On a very tricky topic that most people wouldn't attempt. Did you do any reading about any of the other cases that they'd found of the factor V inhibitor and what other treatments they used? Because it seemed to take them a little while to cotton on to the one that actually worked there. I was just interested.
Yeah, I did a lot of research, and really none of them tell you how they treated it.
It's incredibly. Did you find out the incidence of it?
No. I did read over it, but I can't remember off the top of my head. I could show you some journal articles that I have.
One that I read said that was only 150 cases reported in the literature.
Yeah.
But I don't know.
I think most of them were related to surgeries, though.
Yeah.
But they couldn't really pinpoint exactly what. Most of them do say the bovine fibrin glue, but because they now know that, they've stopped using it. But I think the number of occurrences of a factor V inhibitor is still about the same. So they think that there'll be other reasons. I think a lot of the other ones were the beta-lactam antibiotics as well that sort of predispose the patient to.
And do they usually treat it with the, was it rituximab?
No, that was just in this case. Like I said before, they didn't really go into.
They didn't go into treatment regime.
No.
Okay, thank you. Right. We move on to your next one, unless you want to have a break. Would you rather get it over
would
and
you
done?
like
You
to
probably
have
want to
this
get it
one's
over
only
and
short.
done with. Yeah,
It's
good.
only short.
You probably want to get it over and done with, and then people can go to sleep if they want. Okay, a rare case. Oh, this is very rare. Sarah was telling me that she had a lot of trouble finding any information on this because it's such a rare case. So this should be very interesting. Thanks, Sarah.
Okay. So again, just going to give everyone a little bit of a background. So what is septacaemia? Septacaemia is a serious clinical syndrome resulting from the presence of bacteria or their toxins in the bloodstream. It is accompanied by severe clinical manifestations. So to cause septacaemia, one of the following must be true. The organism is either released intermittently or continuously in large numbers that overwhelm the body's defenses. It can also be that there is an can't even say that today, defect that allows colonization of a site, such as a damaged heart valve. The organism has a protective mechanism that enables it to evade host defenses of the blood, such as a capsule or coagulase enzyme, or there is an impairment of the body's defenses. So patients usually present with high spiking fevers that alternate between shaking, chills, and sweats, and symptoms are often intermittent and interspersed with periods of improvement. Mass inflammation and shock is also common. Shock results from low blood pressure and vascular collapse, leading to multiple organ failure, and septic shock may also occur. Awareness of the signs and symptoms of sepsis allow early recognition and prompt appropriate management of the condition. So here are some common causes of septacaemia. For hospital-acquired, there's usual Staph aureus, E. coli, Pseudomonas, Enterobacter species, and Enterococci. Community-acquired causes of septacaemia are a little tiny bit different. E. coli, Staph aureus, Strep pneumoniae, Klebsiella, Group B strep in general, and Pseudomonas aeruginosa. The diagnosis of septacaemia is made by demonstrating the presence of bacteria within the blood, and this is usually done by blood culture. Bacteria causing sepsis may often be difficult to culture for a number of reasons, and organisms may be present in low numbers, even in severe sepsis. Some organisms may be difficult to grow or may be slow growing in vivo. It is also possible that the organism may only be present intermittently, shedding from a primary focus of infection. Blood samples are therefore usually best taken during the febrile reaction, as this represents a showering of bacteria into the bloodstream from the focus of infection. So here in the hospital, blood samples from patients are collected into aerobic, anaerobic, or pediatric culture bottles, which are used for young or hard-to-bleed patients, and are similar to the ones depicted here. So the bottles are then placed into an automatic blood culture machine, like this one. So specialized liquid emulsion sensors, or LES for short, at the bottom of each culture bottle visibly changes color when the pH changes due to the rise in CO2, as it is produced by microorganisms. Instruments within the machine measure the color changes every 10 minutes or so, and sophisticated algorithms, including a unique threshold algorithm, ensure the early detection of microorganisms, which can be plated and then identified. So here's my case study. So a 42-year-old female with a history of intravenous drug use. The patient was referred to the hospital in early June and presented with sepsis, kidney injury, and acute respiratory stress. It was also found that the patient had influenza A and H1N1, or swine flu, as it's more commonly known. Blood samples were taken from the patient and placed into the automatic blood culture machine to confirm the presence of an organism in the blood. So after approximately 100 hours, growth was detected within the aerobic culture bottle only, and a chocolate and HbA plate was set up. So the Zeal-Nielsen and the modified Zeal-Nielsen showed the presence of acid-fast bacilli, and if you can see, there's one tiny one in that red circle there. So after 3 days, the first sign of growth was found on the HbA. So as you can see here, the colonies that grew were smooth, round, and had a yellow pigment. The gram stain showed beaded staining bacilli, and the organism was found to be oxidase negative, catalase positive, and the Zeal-Nielsen from the HBA again showed acid-fast bacilli. This is a picture of the ZN stain here. There's a fair few more in that picture. So the Vitek IID suggested that the organism was Corynebacterium urolyticum, which is a gram-positive bacillus that is partially acid-fast. However, when it was plated on the Coryne plate, there was no growth even after re-incubation. So a slope of the organism was made and sent to Brisbane for identification. So 2 weeks after the patient presented, the organism was identified in Brisbane as Microbacterium neorum. And the organism was identified by sequencing the 16S recombinant RNA gene. So a little bit about Microbacterium neorum. It is a rapidly growing non-tuberculosis mycobacterium that is ubiquitous in water and soil environments and was first reported in 1972. Transmission of Microbacterium neorum and other non-tuberculosis mycobacterium is not well defined. However, environmental exposure is thought to be the major factor. Microbacterium neorum can also often be found in water pipe systems as a biofilm and is rarely reported as a cause for human infections. To date, there has been a total of 25 reported cases of human infection, ranging from sepsis to skin infection. So phenotypically, Microbacterium neorum is characterized by yellow-gold pigmented colonies, hence the name neorum, which literally means new gold. It is an intermediate or long bacillus which has biochemical results positive for 68-degree catalase, nitrate reduction, twin hydrolysis, potassium tellurite reduction, and susceptibility to polymyxin B and iron uptake. And it also has negative biochemical results for citrate and sorbitol testing. However, these results can vary and identification is more accurately performed using gene sequencing techniques. So little is known about the pathophysiology of this organism. However, patients with septacaemia caused by Microbacterium neorum are typically immunocompromised and have central venous catheters or are intravenous drug users and present with undifferentiated fevers. Other cases of infection with this organism have been associated with dialysis, which usually leads to bacteremia or peritonitis. Can also be associated with injections utilizing reused needles or needles rinsed with tap water, resulting in abscess formation. And it can also be associated with contaminated surgical supplies or instruments, implants, prosthetic valves, suture material or solutions. Surgery is also associated with Microbacterium neorum blood infections, especially when alternative medicine providers are used, which are not routinely monitored by infection control committees or equivalent oversight bodies. In the case of this patient, it was suggested that the infection with Microbacterium neorum stems from her intravenous drug use. The patient could have accidentally infected herself with the organism by using a contaminated water supply, or she may have used contaminated water to wash needles or used it in a solution with the drugs. So while Microbacterium neorum is most commonly associated with septacaemia, it can also be rarely associated with pulmonary infections. To date, there appears to only be 2 reported cases of a pulmonary infection in the literature. So while there is currently little information on the pathophysiology of Microbacterium neorum, it's assumed that it would be quite similar to other non-tuberculosis Microbacterium. Pulmonary infections caused by non-tuberculosis Microbacterium generally result in shortness of breath, and patients often have diffuse abnormalities on their chest radiographs. So unfortunately, the patient mentioned also contracted a pulmonary infection. As you can see on this picture, this was an X-ray taken from around the time the patient was admitted, and a large area of the lungs has been consolidated by the organism. The areas of consolidation are represented by the denser white areas. So this second X-ray was taken only 6 hours later, and shows how quickly the organism has affected the lungs. So in the past, Microbacterium neorum bloodstream infections have been successfully cleared with the use of several weeks of combination antimicrobial therapy. including macrolides, fluoroquinolones, or aminoglycosides, and the removal of any devices such as catheters which may have been the cause of the infection. Mycobacterium neorum has been found to be most susceptible to imipenem, ciprofloxacin, and amikacin. The patient sample was found to be susceptible to all of those, as well as trimethoprim, clarithromycin, tobramycin, and cefoxitin. So the prognosis for pulmonary infections due to environmental non-tuberculosis mycobacteria is variable and often depends on many factors, including the specific species involved and its drug susceptibility pattern, the extent of the disease, presence of other medical problems, and whether or not the patient can tolerate the treatment regime. Unfortunately for this patient, she passed away 3 weeks after presentation, but still interesting to see such a rare case within the hospital.
Another very interesting case. That was amazing. So has anybody got any questions? Hey guys from Emerald, you still awake?
Yeah, we're awake, but no questions. Thanks. Very good.
Very good. Anybody here? Amy?
I've got a quick question.
Yeah.
How does an alternative medicine provider perform surgery?
I think it was not just surgery.
With a knife.
Is that where they like put pig guts on you and
Maybe
go like
when
this and
they,
pretend they...
Not just surgery, but it could be acupuncture even.
Yeah,
You've
anything
got a
that
needle
penetrates.
that they could have washed with contaminated water and jabbed into the person.
The thought of it horrifies me.
It just makes you wonder if she wasn't infected with the organism and then because she got the flu became immunocompromised and then it took control.
Well, they have also found, I got a little bit worried when I read over this, that neorum can often be found in the treated water pipes of hospitals.
Yes.
So because she would have been immunocompromised, she could have also gotten it from the hospital as well. Yeah.
I'm sure the microbiology department looked into that.
Just a question. The ZN, what triggered the scientists to do a ZN? Because that is a very, one organism in the entire field. That's very, difficult to find. What triggered them to do a ZN?
I'm not sure.
I think they saw the beaded appearance of the...
Yeah, I think
And
the beaded probably
probably-
makes them think of corani, which is also partially acid
Partially
fast.
acid fast.
So they might have just been checking for the corani bacterium
I
instead.
thought there was a hint there in that when she said that the Corani was partially
Yeah.
acid fast and it had come up as a Corani on the...
Where's Mark when you need him?
Yeah.
Yeah.
Immediately disappeared.
Don't worry, ask him.
Yeah, ask him.
All right, thank you very much. Well done, Sarah. Well done to that.